So first I'll be talking about the radio frequency. So my slide is visible?
Yes, sir. Yes, sir.
Okay, thank you. So radio frequency, exactly what it is. So there are lots of myths, misconception, many things that radio frequency means something you are doing it from a distance and you are getting some lesion, even though there is no physical contact. But this is not the reason why this is called radio frequency. So radio frequency is a term used because it is using the alternating current. You know, there are two types of current. One is direct current, one is alternating current. Direct current means where the flow of current always in the given direction from one electrode to another electrode. And what is alternating current? Here the direction of the current is changing from one to another. So how frequently it is changing, that is the frequency. So frequency of the current is very important in radio frequency. And this frequency, you know, the household current frequency, it is 50 hertz. And here in the radio frequency, the alternating current what is used is more than 300,000 hertz. So you just can imagine how fast it is. 1 hertz means 1 times it is changing its direction, 1 time. And 50 hertz means household current. 50 times it is changing its direction per second. And you just try to imagine 300,000 times it is changing its direction. And why it is called radio frequency? Because this frequency range is similar to that of the radio wave transmission. So radio wave transmission uses the similar frequency band, and that is the name came radio frequency. Otherwise, there is nothing, you know, some feels radio means something, you know, there is the center through which it is being transmitted, and you are getting it in a transistor, you are getting a receiver, or you are receiving it, so there is no physical contact. That is why it is called radio. No, that is not the reason why it is called radio frequency. So radio frequency term is used because of this. It uses the alternating current whose frequency is similar to that of the frequency range of the radio wave transmission. So radio frequency procedures, ablation procedure is one of the very important procedure in our pain management. To give a long-term pain relief, the steroid injections and the other kind of injection are not enough. Many times we need to ablate some of the structures, particularly the nerves, to give the long-term pain relief, and that is possible, the best possible, by radio frequency ablation. So first, before I'm coming to the topic of the radio frequency, I'll be talking a little bit about the neurolysis. So what is neurolysis? Neurolysis means we are ablating a nerve. Which nerve? Most commonly the pain-carrying nerves, but sometimes neurolysis is also done sometimes by the physical medicine people to relieve the spasticity. If you are ablating a motor nerves, peripheral nerve, lower motor nerves, then what will happen? There will be flaccid paralysis. So that can be sometimes utilized to relieve the spasticity in some of the patients, and sometimes it is used in the congenital spastic cerebral palsy, or sometimes in some of the traumatic or any other kind of the spastic paralysis, where we can ablate the lower motor nerve and we can relieve the spasticity. But that is rarely done. Most commonly done, the common indication of this neurolysis is your ablation of the pain-carrying fibers to reduce the pain. So now another kind of radio frequency is available. Nowadays it is available, but it is very high power radio frequency, I should say. That is your ablating the cancer cell itself. Suppose there is a tumor mass in a vertebral mat. So sometimes with the radio frequency, you can ablate the generation of the heat, you can ablate the tumor mass. Just the opposite way, I'll be talking about the cryoneurolysis. So similar way, by generating a cold lesion, we can also ablate the nerve as well as we can ablate the cancer mass. So now neurolysis is commonly done by which? One of the old option was surgery, seeing the nerve and ablating it. Nowadays it is not done commonly because we are having a lot of Parkinson's technique. But nowadays, recently one important way to do the surgical ablation of the nerve is your endoscopic surgical dissection. So there are many literatures which is showing that endoscopically we can identify the medial branch, the facet joint, and we can ablate the nerve. So in the same way, endoscopically, we can identify the lateral branches which is supplying the sacroiliac joint, and you can ablate those nerves. though it is not yet established, but this is one of the options where you can directly visualize the nerve and you can ablate the nerve. Most commonly, most primitive, I should say, is you're injecting some chemicals for the ablation of the nerves. And there is, if you are searching the literature, you'll be getting a long list, at least 15, 20 chemicals have been used to ablate the nerve. But recently, currently, all those chemicals are not approved by US FDA or other regulatory authorities to ablate a nerve. So right now, the chemicals which are approved for the US FDA and the other regulatory authorities for the approval of ablation of the nerve are only four. What are these? Alcohol. Alcohol, again, percentage varies. It can be, if you are ablating the smaller diameter sympathetic fibers, then the concentration is 50%, 60%. If we are ablating the motor fibers, normally motor fibers are not our target. Still, if it should be more than 80%. And if you are ablating the other sensory fibers, then the concentration should be around 60 to 80%. Phenol is another. Advantage of the phenol is that it is a painless injection. Alcohol is a very painful injection. So if you want to inject alcohol before that, you have to always inject the local anesthetic. But phenol itself is like a local anesthetic. So if you're injecting the phenol, then it will be having the local anesthetic activity, and then gradually there will be the neurolysis. Disadvantage of the phenol is that it is a shorter duration of action. The nerves will be getting regenerated very fast. Alcohol and phenol are mostly used for the celiac plexus neurolysis. Sometimes it is also used for the superior hypogastric plexus neurolysis, and very rarely sympathetic, lumbar sympathetic. But lumbar sympathetic and superior hypogastric are nowadays done mostly by the radiofrequency as well. So the celiac plexus is always done by the chemical neurolysis. You know why? Because celiac plexus is a very big plexus. It's lengthwise it is approximately 5 centimeter, wide is 3 centimeter, depth is your 2.5 centimeters. So such a big area of the lesion, and those network of the nerves is around the celiac trunk. So you cannot ablate the nerves fully with the radiofrequency or any other things. Only option for the celiac plexus is the chemical neurolysis, where you are injecting the chemical will be moving around the celiac trunk into that plexus, and you'll be having the neurolysis. So the phenol and alcohol are still the choice for when you're doing the celiac plexus, and sometimes in superior hypogastric. In other situations, it has been replaced by the radiofrequency. Glycerol is used particularly only one indications, that is your Gasserian, retrogasserian glycerol injection. And here you have to inject the anhydrous glycerol. Anhydrous glycerol means you must not be diluting with the water. So it should be full concentrated glycerol. And there, how it is working, how glycerol works, it imbibes water, it swells up, and it presses the Meckel's and the Meckel's cave, the Gasserian ganglion against the bony wall, and that is how it works. That is the reason why glycerol is not a neurolytic agent if you are injecting in a peripheral nerves where there is nothing, there are no other bony structures there around it. If you're injecting glycerol, so it is not going to help much. Hypertonic saline is another. Hypertonic saline means this hypertonic saline is not commonly available in India. In India, 10% hypertonic saline is needed. So 10% hypertonic saline is unfortunately not available in India. You can prepare it with your pharmacy. But otherwise, 10% hypertonic saline is used in one condition again. Suppose you are doing an epidural adhesiolysis, and after that, 10% hypertonic saline is advised to be injected. Though it is not commonly done because of the not available in India, but it works in the two mechanisms. One mechanism, it absorbs the edema fluid around the neural tissue. And second important mechanism is it has some neurolytic effect over the small diameter C fibers. So these are the 4 chemicals still now approved for the neurolysis. All other chemicals, I just told you, the long list of chemicals are there in the, if you're searching on the internet, those are no longer in use. So these are the chemicals. So how I discussed, one was surgery, next was chemical, next is thermal ablation. Again, thermal ablation, only option is many fellows ask me the question. In my hospital, there is no radiofrequency, but there is very high-end diathermy machines. Can I use those diathermy machines for ablating? The answer is simply no. So why no? Because most of the times we are using this neurolysis very close to the other structures, like close to spine, very nearby other important structures are there. So radiofrequency ablation, what is the advantage of the radiofrequency ablation? I will be coming to that point later on. That it don't disperse any small amount of the heat. Means where you are doing it, listen will be approximately 2 to 4 millimeter. Beyond 2 to 4 millimeter, there will be no heat. Nothing will be there. What is the principle of that? I'll be coming to that later. So if you wish to do a thermal ablation, then your only option is your radiofrequency ablation. And your cold lesion is also another option. That's opposite. So thermal lesion is normally done somewhere between the 60 degree to 90 degree. And whereas the cryoneurolysis, I'll be coming to the cryoneurolysis lecture after this lecture. And there I'll be talking about the different degrees of the neural lesion. So cryoneurolysis causes the cold lesion. And normally, most commonly it is used something between the -78 to -90 degree temperature. So that is where we can produce a second degree nerve lesion. And that is another option for doing the neurolysis. And last one, again, not the least, and very important, particularly when we are doing the gasserian ganglion. It's a balloon compression. Mechanically, you are compressing the gasserian ganglion against the bony wall, and by mechanical compression, you can ablate the nerve. So these are all the different options, different ways you can do the neurolysis. But now I'll be concentrating on the radiofrequency.
Sir.
Yes, yes.
Sir, can you please explain the mechanism by which hypertonic saline acts?
Hypertonic saline acts by the two mechanisms, as I told you. One mechanism is the chemical one, by which it causes it imbibes the water, water inside the neural tissues, and thereby the nerve is ablated. That is one. And another thing, as I told you, that the perineural tissue edemas are also there, which will be absorbing the perineural tissue edema, and that is also helpful in. So this is not neurolysis mechanism, the perineural tissue edema absorption, but the neurolytic tissue mechanism is here. It will be absorbing the fluid because it is hypertonic. It will be absorbing the fluid from the neural tissue, and thereby it will be causing the neurolysis. Clear?
Yes, sir. Thank you.
Okay. So advantage of the neurolysis are what? That you don't need medicines, or you can reduce the medicines, so the side effects of the medicines are reduced. Like, say, for example, somebody who is in the cancer pain, lots of opioids, and now we have done a celiac plexus block, so pain is relieved, and now we can do the opioids. So long term it will be cost effective and long term pain relief. So all these are advantages. Disadvantages are also there. Failures are there. You have to precisely locate the nerve, otherwise you will not be able to get results. Initially it is costly. The inadvertent damage to the other structures, particularly the other nerves, which is not your target. Like you are trying to ablate a somatic nerve, and nearby was your motor nerve, and unfortunately, inadvertently, you ablated the motor nerve. So what will happen? The patient will end up with the paralysis. So these are important. And last one is very important. In my first class, all of you, I'm sure that all of you have attended my first class. I explained that the mechanism of the deafferences pain. So this is applicable for the mixed peripheral nerve. So when you are ablating a mixed peripheral nerve, then what can happen? The two important mechanisms. This I discussed in my first class when I discussed about the pain pathway. So nerve will be regenerated depending on which degree of nerve lesion it is. If it is a second degree nerve lesion where the endoneurium is intact, then the which is called axonal process. So there will be complete regenerations, no sequelae. But if it is a third degree, fourth degree lesion, then what can happen? Then during the regeneration process, two things can happen. One is crosstalk, means one kind of fiber will be exchanging the signal with the other kind of fiber. That means suppose A beta fibers, and it is exchanging the signal with the A delta fibers. So what will happen? So allodynamic mechanism. And another things I explained there, that the ectopic signal generation. Why? Because sodium channels are proteins, and these proteins are being manufactured within the nerve cell body. And then these proteins are distributed all around the axons of dendrites. And these sodium channels, if there is a damage of the nerve, this sodium channel gets accumulated in the damaged side, and that becomes the source of the ectopic signal generation. So suppose, this is a very common question even by the patient, that this area, this limb is so painful. So why can't you ablate the nerve? Like somebody, there was also an attempt, that phantom limb pain. If you're ablating the nerve, will the phantom limb pain go? Answer is, this result will be very temporary. After that, the pain will be again coming back. Suppose there is a herniorrhaphy operations, and the ilioinguinal and iliohaplus nerve is entrapped, and you are doing that surgically finding out the nerve and you are dissecting it. Will the pain will be relieved? Answer is, pain relief will be for a short-term period. And that is the reason why, if it is a mixed peripheral nerve where the sensory supply is also there, you can't cut that nerve. You can't ablate that nerve. Because if you are ablating the nerve, the pain is going to come back and it will be more intense. It will be more neuropathic. And a very common example is somebody is having a traumatic paraplegia. After some time, he'll be developing the the paraplegic legs. Patient will be having the very severe intense neuropathic. So similar kind of mechanism is there in the phantom limb pain and many other areas where the area is numb, but from that numb area, pain will be coming. So it is a very bad condition, and that is the reason why the mixed peripheral nerve ablation, we have to think not twice, thrice before ablating a mixed peripheral nerve. This complication is not there for the sympathetic nerve. Suppose you are ablating a sympathetic nerve. This complication is not there. Why? Because the somatic fibers are not there. It's not a mixed fiber. It is not the exchanging the signal. So these crosstalk possibilities are not there. So you can easily ablate the sympathetic fibers. But where there is a mixed fiber, where there is a touch fibers, so before ablating it with heat, always think twice. There are other options. I'll be coming to that later on, but don't ablate it if it is, or you think, and that is the reason why the gastric ganglion is also deafferences and pain is seen. You have ablated the nerve, gastric ganglion. After some time, the pain will be fine, and after some the pain is very intense, and it is the different character of the pain. So this can happen in 5% situation, deafferences. So now, before understanding the radiofrequency, you should understand a little bit about this. So certain things you have to know. One of them is voltage. So what is voltage? Voltage is the potential difference between the two waves. So suppose there is a, the water is flowing from the inner pipe. So the water will be flowing in which direction? From high pressure to the low pressure area. Same way, current will be flowing from higher potential to lower potential. There must be potential difference, then only there will be flow of current. And how fast the current is flowing, that is unit is your ampere. And ampere depends on another thing is your resistance. And last one, very important, is wattage. This is finally this, you have to understand what is wattage. So wattage is the multiplication of the voltage and ampere together. Multiplication is your watt. And finally, if we are asking about a machine, or suppose a electric bulb or a tube, you talk, okay, it is a 5 watt tube, or it is a 30 watts bulb. So what is the meaning of that? Meaning is power there generated in that bulb or in that machine is 30 watt or 5 watt or something. So what is that? This watt? Watt means voltage into ampere. So when we'll be talking about the radio frequency, the heat generation, the size lesion generation, again, the same thing. How much is the watt we are using? And this watt is not in your hand. I'll be coming to later on that how this watt, the watt and your size of the lesion is directly proportionate. So more is the wattage, the size of the lesion will be bigger. The less is the wattage, size of the lesion will be smaller. So Hertz, voltage, B, ampere, and wattage. And to remember wattage. Now, what is the principle of RF? I'll be coming to this figure directly. So this is the radio frequency machine. So this machine receives input current is your household current, domestic current. What is the domestic current frequency? It is 50 Hertz alternating current. That means here the current is alternating. Means there is 2 electrodes. So the current is changing its direction 50 times per second. But what a radio frequency machine does? So this radio frequency machine, now it is changing the output current into 300,000 Hertz. That means here the current is changing its direction 300,000 times. And now to flow electricity, there must be 2 electrodes. So here is 1 electrode and here is another electrode. So here the electrode is a larger areas so that no lesion is there because current will be divided in a wider area. So it will not be producing a lesion. But here, because it is a concentrated area, a small area, and here the lesion will be there. How the lesion will be there? Because when you are putting the current, the electrodes there, what will happen? How the current will flow in a body? Because there are charged particles inside the body, in a living body. The charged particles will start oscillating when we are putting 2 electrodes. And how fast they will be oscillating? They will be oscillating at a frequency of 300,000 Hertz. So this 300,000 Hertz movement of a charged particle, there are lots of non-charged particles. There are lots of oppositely charged particles. So they'll be creating the friction between the oppositely charged and the non-charged, and that is going to create heat. So here you have to remember that the electrode itself is not getting heated. What is it? It is the charged ion within the body which starts oscillation, and it is creating friction to the oppositely charged ions or the non-charged ion, and that is going to create the lesion. So now, why the lesions will be there only located to the electrode? Why not away? Because again, because the current is going to disperse if we are going to move away. And how do you have to remember? The higher is the frequency, more is the precise the size of the lesion. So no heat will be dispersed, something around 2 to 4 millimeter around the electrode. Beyond that, there will be no heat at all. So that is the reason why this is very safe to use the radiofrequency, the lesion in the spine or around the area other nerves, or you don't want to make any damage to the surrounding tissues. So now another very important thing is there, that the different, what exactly is the electrode? Electrode is nothing but a insulated needle. So gauge of the needle might be varies. You can take a larger gauge needle, you can take a smaller gauge needle, and through which a 27 gauge probe will be inserted within that cannula. So it's just a needle which is insulated, tip is open, and how much tip is open? That is the electrode size. The length of the electrode might be something around 2 millimeter to 15 millimeter. If the length of the needle, exposed tip, if it is more than 15 millimeter, what will happen? The current will be dispersed in a wider area and there will be no lesion. So to have a lesion, the maximum size of the lesion we can create with the radiofrequency generator is your lengthwise is your 15 millimeter. Width is fixed. You cannot create more than 2 to 4 millimeter size beyond it. And at the tip, the lesion size is even smaller. It is 2 millimeter, not even up to the more than 2 millimeter at the tip. So if you are looking about the shape of the lesion, the shape of the lesion, I'll be showing the shape of the lesion. Here is the shape of the lesion. So here you see the lesion size here is more than the tip. Here it will be something between the 2 to 4 millimeter, but here it will be not more than 2 millimeter. So the size of the lesion is like a cylinder, and the maximum is at the shaft, nothing beyond the tip. Why it is important? Suppose a nerve is like this, and if you are putting a needle like this, you might be very close to the nerve, but still there will be a very high chance of failure, because you have to be on the nerve, then only you will be having. So to have the better success rate, what you have to do? You have to put the needle not perpendicular like this. You have to put the needle parallel like this. So if the nerve is like this, not exactly parallel, that is not possible. If the nerve is like this, and if you are putting the needle like this, so larger area of the nerve will be covered, more chances of success. So this is what I am calling is your conventional radiofrequency. So for the conventional radiofrequency, the needle should never be targeted perpendicular to the nerve. If you are trying that, your failure is obvious. So what do you have to do? If it is your nerve, if it is your needle, so your needle should be coming like this, so that you can catch a larger area of the nerve, so that your size is the effect will be more. I'm coming to the other point later on. So now before coming to the other important areas, what I was telling, that here there is a 27 gauge thermocouple which will be inserted inside it, and these electrodes are made up of certain metals. Characteristics of the metal is here that it is made of thermocouple which can sense the surrounding tissue temperature, and it will be sending that feedback to the machine. Suppose you are thinking of doing a lesion at 80 degree temperature. 80 degree temperature is the most common temperature we select. There are other selection up there. I'll be coming to that later on. So 80 degree. Now we have started radiofrequency. Now the temperature is going up. It reaches the 80 degree. So your machine is, the electrode is sensing the temperature, sending the feedback to the machine. And when the 80 degree is reached, the machine will be telling, okay, now 80 degree is reached. So now I have to do something. If I'm not doing something, what will happen? The temperature will be going, even 90, 100, more than 100 also. Now the structural tile will start boiling there because of the water, and the nerves will be getting charred. So we don't want that, because that is going to create a fifth degree lesion, and that is very bad type of lesion will be there. So we want 80 degree. So how 80 degree will be maintained? So by reduction of the wattage. As I was telling you earlier, so if it is a conventional RF, suppose this is your, now you have reached the temperature here. This is your the wattage. Say for example, it is 30 watt. I'm just telling you. At 30 watt, when it is reached, now your temperature 80 degrees is reached. So now what will happen? If we are not reducing this 30 wattage to 28, 27, then this temperature from 80 will be going higher to 81, 82 like that. So now what will happen? The wattage will be coming down. From 30, it will be coming to 29, 28. So now it will be coming down. So it will be coming, say for example, 25. And now the temperature also will be coming to 79 degree. As soon as it is coming to 79 degree, again the wattage will go high. And that way, the fluctuation of the wattage will be there. That means, as soon as your tissue temperature is reached to a desired level, your wattage will be coming down. Machine itself will be sensing it and machine itself will be doing it. And when the wattage is coming down, the temperature also will come down. And then once the temperature is coming more than 1 degree, that means 80 degree was the set temperature. If it is coming 89 degree, again wattage will start coming. The more sophisticated is the machine, more is this range of the temperature is much more precise. So like say for example, instead of 79, it can be 79.5 or it can be 79.9. As soon as it comes to 79.9, again the wattage comes above. As soon as it is going 80.1, again the wattage comes down. So in that way, by fluctuation of the wattage, you are keeping your tip temperature at a constant. But here, what we are compromising? We are compromising on that when the situations, when you want a big size lesion, to have a, the more sure lesion, the sure success. If you are having a large size lesion, you are basically, it's like a carpet bombing, big size bomb to damage in the bigger area. But in the radio frequency, that is not possible. As I told you, the length maximum is your 15 millimeter, wide maximum is your 4 millimeter. So to create larger size lesion, this is not possible. Why not possible? Because we are compromising with the wattage. So wattage, if you are reducing the wattage, if you are not allowing the wattage to increase, your size of the lesion will also not increase. So there are certain options to increase this lesion size. I'll be coming to that later on. But before that, let me talk about your pulse rate frequency. So what is pulse rate frequency? In the pulse rate frequency, you see that we are giving in short pulses. Means this high frequency of 300,000 hertz for, say, for example, 20 millisecond. And then we stop it. And then 450, 480 milliseconds, we are not giving any current. Then again, you are giving 20 milliseconds. So if you are giving in a short burst of high frequency current and giving a long silence, then what will happen? Then the temperature is not allowed to rise. And in that way, you can create still some lesion. If you are asking that, okay, if temperature is not raised, what is the benefit? How the patient will be having the pain relief? So this is still a mist. How the pain relief is there, lots of hypotheses is there. But one of the things is this one, what I was telling you, that whenever it has been seen that whenever the electricity flows at a very high frequency, there is a generation of the electromagnetic field. So this electromagnetic field will be generated more in the tip than in the sac. So in that tip, the electromagnetic field will be generated. It is not going to create any thermal lesion. There will be no tissue ablation there with the electromagnetic field. But what will happen? It will have some modulation effect of the nerve. So exactly what modulation effect? Still under research, still nothing convincing. But still there are some hypotheses which are popular. One of the hypotheses which is still popular is that it generates, it manufactures certain interleukins which are anti-inflammatory in nature. Some of the publication has shown that the anti-inflammatory interleukins, I don't remember exactly, probably IL-10, something like that. Means there are a long list of interleukins. Some of the interleukins are pro-inflammatory, some of the interleukins are anti-inflammatory. So in the pulse rate frequency, when the strong electromagnetic field is generated, so anti-inflammatory interleukins, because some studies have shown it. But again, this is not consistent. Some study again has not shown this rise of the interleukin 10 of these things. So exactly how it works, still not known, but it has been seen that in certain areas it works very fantastic way. Like say, for example, if we are doing a lesion close to the dorsal root ganglion, if you are putting the electrode close to the dorsal root ganglion, so then the patient will be having very good relief of the radicular pain. And here you don't have any option because you cannot thermally ablate a dorsal root ganglion because very close is your ventral root, motor root. You might be ablating the motor root. So here your only option is to do a pulse radiofrequency of the dorsal root ganglion, which can be given you a good result. So the pulse radiofrequency is one option which causes a non-ablating, non-thermal lesion. So here temperature is allowed to rise up to 42 degrees. 42 degrees is never going to create any lesion inside the body. To have any damage in the tissue, thermal damage of the tissue, your temperature must be rising above 45 degrees. Otherwise, there will be no damage of any tissue in the body. So it is kept at 42 degrees. That means it is not going to do any ablation, any damage, but still the pain relief might be possible because of the strong electromagnetic field there at the tip of the electrode. But as I told you, controversies are till there. We rarely do it except for the dorsal root ganglion. We rarely do the pulse radiofrequency. So now another kind of radiofrequency. So pulse radiofrequency, it causes the stimulation. There is no nerve damage. It's safer, and there is no differentiation pain. Why? Because you are not damaging anything. So there is no question of any nerve ablation, no differentiation pain. So now these are the difference between the conventional. I have told you one thing, and another thing is you have to remember the pain-free period is less compared to that of the conventional radiofrequency. And another thing I have to remember, high failure rate in the pulse radiofrequency compared to that of the conventional. Now comes cool radiofrequency. So what I told you earlier, that once your tip temperature has reached to your desired set temperature in the machine, so now machine has to take care of the tip temperature that it is at that level. It is not rising or not falling down. So for that, what is important? It is your fluctuation of the power of the electricity. And by that way, what we are compromising? We are compromising with the size of the lesion. We are unable to get a large size lesion. So here comes the cool radiofrequency. So what is cool radiofrequency? So cool radiofrequency, in its cannula, there is a channel. This blue color is the channel through which the water circulates at room temperature. So when the water circulates in the room temperature, from the tip, it will be taking away the temperature. So here, the control of the tip temperature is not by reduction of voltage. So the control of the tip temperature is by circulating water. The water will be taking away the temperature. So what will happen? You will be able to create a lesion even with a higher voltage. So you can deliver the current with a higher voltage. What is the advantage? You are going to get a large size lesion, and the lesion also will be spherical lesion like this. That means beyond the tip also you'll be getting a substantial portion of the lesion. So here you can put a needle perpendicular because beyond the tip you are having a considerable area of the lesion, and it is also called angle independent because it is a spherical size of lesion. So whether your nerve is like this, whatever you are putting it, because it's a large football size, spherical size lesion. So any angle you can put the needle, and which will be very easier to maneuver. You can put it from any angle. You can do it. The most easy way to do the procedure is your tunnel vision technique. So the tunnel vision procedure is possible with the cool radiofrequency, but not with the conventional radiofrequency. So here the power remains higher. Here the larger size of the lesion is possible and spherical size of the lesion. And because it is spherical, so it is angle independent lesion. So now another kind of radiofrequency is known as bipolar radiofrequency. What is that? So the bipolar radiofrequency, so this is not there. So here the current flows between these two electrodes. And what is the advantage of that? So here there was no lesion. Why? Because the current is dispersed in the wider area. But if it is a small one, the lesion will be there. So now here, if you are putting the two electrodes side by side, so there will be two lesions together, and it will be creating so one lesion, another lesion. So ultimately, it will be dumbbells up at large size lesion. So another way to make a larger size lesion is to do a bipolar lesion. But again, disadvantage of the bipolar RF is here that the tip of the electrode will not having a lesion. Side of the electrode will be having the lesion. Whereas the full radiofrequency tip beyond the tip of the lesion electrode also will be having some good amount of lesion. Now there is also multi-channel lesion. Multi-channel lesion means like here in this machine, what I'll be demonstrating today, have the two-channel machine. Some machines are 4-channel machines. So what is the meaning of that? So here, the current will be flowing not between these two. If the current is flowing between these two, we call it bipolar. But if the current flows between this and this separately, so there will be two separate unipolar lesions. So what is the advantage of that? So in the bipolar lesion, normally what happens? One electrode is a passive, another is your active. So what will happen? The one electrode, one size will be bigger size lesion, another might be having a smaller size lesion. This possibility is there. But when you will be having a multi-channel lesion, then the both will active electrodes and both will be having a larger size lesion. So that is the reason why the multi-channel lesion can create a, if you are keeping it together, you'll be having a larger size lesion. Or you can have it in a wider area. So one lesion here, another lesion here. Like say, for example, when you're doing the facet joint. So one facet joint, L4, 5 facet joint. You need to have put the needle both on the L4 transverse process as well as L5 transverse process. So for one joint, you need to have two. If you are doing the multiple lesions, then you can put all the electrodes at the desired area and then you start the machine so that your time will be saved. So you can easily, quickly do the procedures. So that is the advantage of that. And not only that, you are creating both our electrodes are active electrodes and you are having the larger size lesion in the both the electrodes. So this is called multi-channel lesion. So understand the different types of radiofrequency. One is conventional. I told you it is a smaller size cylindrical lesion. Second, we call about the pulse radiofrequency. In the pulse radiofrequency, we told that this is not a thermal lesion. It is going to cause a electromagnetic field effect. Then he called about the cool radiofrequency, where the temperature is controlled not by the reduction of the wattage, but by the circulating water inside the electrode. And that going to produce a large size, spherical, the beyond tip, angle independent lesion. Then we talked about the bipolar lesion. Bipolar lesion is two electrodes side by side. And then we call out the multi-channel radiofrequency. So all the different kinds of, the varieties of the radiofrequencies. Now coming to the cannula, radiofrequency cannulas. So it can be straight or carved. This is the carved one. As a carved one having the advantage that you can manipulate the needle easier. Gauge, it can be from 22 gauge to 14 gauge. And this is one of the options by which you can have a larger size lesion. You see the diameter of the 22 gauge needle is 0.64 millimeter. Whereas 14 gauge needle is your 1.6463. That means you can have a 1 millimeter larger size lesion if you're using 14 gauge. But again, if you are putting the needle larger size patient, it is not patient friendly. But still, if you are wish to do a large size lesion, it is one of the options is to take a large size needle, large gauge needle. And exposed tip can be the different varieties of the exposed. Now some of the newer cannulas are happening. This is called protruding cannula. So what is happening? So one, the metal, small strip of the metal will be coming out and it will be having a large size lesion. Then cool radiofrequency already discussed, spherical lesion. Then the venom cannula, where there'll be, like this. Then trident cannula. So all these different kind of cannulas are there to increase the size of the lesion. But ultimately, the largest size of the lesion is possible only with cool radiofrequency amongst all other options. So these are the different shapes of the lesion. Now, if we are giving the radiofrequency for a longer time, are we going to create a large size lesion? Answer is partially yes. Why? Because initially, you see, up to 30 seconds, it is almost proportionate. Means more time, more is the size of the lesion. Then gradually, it comes to a plateau at around 60 seconds. Still, it will be going to create a larger size lesion. But after 2.5 minutes or 150 seconds, there will be no increase of the size, even if you are giving the radiofrequency for a long time. So most commonly, the recommendation is if you are doing a conventional radiofrequency, so put it from something between 60 to 90 seconds, sorry. But if you are doing a cool radiofrequency, you keep 2.5 minutes. That is normally standard recommendation. So if the question is coming, is time and lesion size, is there any relation? Answer is yes. If you're giving larger time, the size of the lesion will be increasing, but up to a certain extent. After that, lesion size will not increase. So this is a very popular MCQ, multiple choice question. How to increase the size of the lesion? One is increase the gauge of the needle, increase the time. Again, I told you up to a certain extent. Use cool radiofrequency, use bipolar radiofrequency, use neuro cannula. So these are the options by which you can have a large size lesion. Sometimes you need a large size lesion, like in the sacroiliac joint, like in the genicular nerve of the knee joint. We need a large size lesion so that your success rate is increasing. So now, how to confirm that you are close to the nerve? You cannot see the nerves from outside. Sometimes you can see the nerve with the ultrasound, but most of the times, very small nerves also you cannot see the ultrasound. So the most important part is you always under the image guidance. Most commonly it is done under the CM guidance. The CM, what you can do, we can see the bone, and we know the anatomy, that the nerve and relation with the bone. So put the needle in the onto the bone, close to the bone, and then we stimulate sensory stimulation, motor stimulation, which will be telling you that whether you are close to the nerve. And nowadays we more do with the ultrasound. Smaller nerves can be seen, but more commonly we look at the vessels, because most of the time vessels are accompanying the nerves. You can see the vessel, then we can accordingly we can put our needle, and thereby we can do the lesion, which will be increasing the success rate. So sensory testing means you are delivering the current at 50 to 100 hertz, and the patient will be having. So you must be remembering the rule. To stimulate the larger diameter fiber, you need a lesser frequency current, and to stimulate the smaller diameter fiber, you need a higher frequency. So if you should test the sensory fibers, so put there, ask the patient to having any paresthesia or not, at which current. The same radiofrequency machine can deliver current, at 3000 hertz, not only 3000 hertz, you can at any range. So that if you are delivering the current at a 50 hertz, and if the patient is feeling the paresthesia, that means you are close to the nerve. But again, there another parameter is there is voltage. If you are stimulating, the voltage should not be more than 0.5 volt. If you have more than 0.5 volt, means even if you are away from the nerve, even then you can stimulate it. So that is not desirable. And also you should do the motor testing. Why motor testing? Motor testing is more for the safety. That means you should not be doing the current. If you are passing the current at 1 to 2 hertz, there should not be any contraction, inadvertent contraction of the nearby motor nerves. So motor testing is mandatory to add safety. Sensory testing is mandatory to give success. So success by sensory testing, safety by motor testing, and then only you should. What is sensory motor dissociation? Sensory motor dissociation means you are able to stimulate the nerve, sensory stimulations, means paresthesia, at a certain current, and you are unable to stimulate the motor fibers. So this is called sensory motor dissociation. So now what are the indications? Here are the indications. Gastrin ganglia. What should we do? These are all conventional radiofrequency. Spinopalatine, third occipital, cervical facet, T2, T3, splanchnic, lumbar sympathetic, lumbar facet, thoracic facet. So these all are conventional radiofrequency. Some of them is also done by the cool radiofrequency nowadays, but these all are indication for the. So what I'll do, I might be sharing with you also. Very recently, just 6 months ago, we had a publication of the radiofrequency guideline by the Indian Society for Study of Pain. So I was the chairman of this guideline committee. So there we have recommended that what kind of radiofrequency should be done, how to be done, in which condition it should be done. So it is there in the Indian Journal of Pain. It can download it freely, or what I can do is I can share this guideline with you and you can go through that. So all the common radiofrequency procedures are there, and what kind of radiofrequency should be done, which is based on the different evidences. So we had the meta-analysis, systematic review of the literatures, and then we went to the different experts who are practicing radiofrequency for more than 10 years. So basically this guideline was framed based on both your evidence as well as the experience of the from India and abroad. And finally, we came to a conclusion, and we have framed different guidelines for the different painful conditions. All common conditions, starting from the gastrin ganglion up to the knee, everything has been covered in that guideline. So I'll be asking you to go through that guideline. You can download it online from the Indian Journal of Pain website. You must be knowing the Indian Journal of Pain website address, www.indianjpain.org. as the chief editor of this journal 4 years, from 2012 to 2016. So anyway, so this guideline might be very useful in your practice. So the pulse radiofrequency, as I told you, this is the indication. Still now it is done, but other indications are, nowadays becoming obsolete. Why? Because the failure rate is very, very high, and that is the reason. If you are doing some procedures, high-end procedures, without any result, person don't like it. So that is the reason why still these are the indications. If it is coming in the multiple choice question, so then occipital nerve, suprascapular nerve, intercostal nerve. Why can't we do the conventional radiofrequency here in these situations? Because all these nerves also have the sensory supply. So if you are ablating that sensory supply, the patient that area will be numb and de-appearances and pain will be developing on that area. That is the reason why these areas you cannot do the conventional radiofrequency. And cool radiofrequency. Cool radiofrequency in certain areas very high evidence. One of them is a sacroiliac joint. One of them is a knee joint. So these two areas, the cool radiofrequency has a very high evidence, and some evidences for these situations as well. The hip joint articular branch, the shoulder joint articular branch, the lumbar facet medial branch. These are the areas where you can also do. But these first two indications are very important indication for the cool radiofrequency. Then comes bilateral, bipolar radiofrequency. Bipolar radiofrequency is almost similar. Means here also we are going to get a large size lesion, and it might be similar to that of indications are almost similar to that of the cool radiofrequency. So thank you very much. And if you have any question, you can ask me before I go to the cryoneurolysis.
Sir, the website you told for the journal?
indianjpen.org. Indian Journal of Pain. Don't worry, I'll be sharing this PDF file with you. I'll be posting it in your this thing.
Okay.
So this was published just this year, February only. It was published. So it's not yet 6 months, only 4 or 5 months.
Okay, thank you.
Excuse me, sir. I have a
Sir,
doubt.
sir,
Yes.
Sir.
Sir, he told in bipolar radiofrequency, only tip cannot produce a lesion.
Beyond tip, lesion size will be very minimal, only less than 2 millimeters. But size of the, just try, let me explain you. I'm showing you the size of the lesion here. Suppose this is one electrode, this is one electrode. So what will happen to this? Like this? No, sorry. Tip is up to here. So beyond
Sir,
the tip.
couldn't see.
Oh, sorry. I have stopped sharing. Have I stopped sharing?
Yes, sir.
Okay, I'm sharing again. Can you see now?
Yeah. Yes, sir. Fine.
Okay, I'm just trying it again. What happened?
All the radio frequency, the tip only will deliver the current. No, sir.
What?
In all radio frequency, all the radio frequency ablations, the tip of the probe will be delivering the current. No, sir. Cannulas.
This is the radiofrequency channel. So this is insulated part. So the current will be delivered from this part. Okay.
Okay.
So now shape of the lesion for the conventional will be like this. For the
Okay,
cool, shape of the lesion will be like this. For the bipolar, shape of the lesion will be another needle here. So bipolar, it will be like this. So beyond tip, in the bipolar also, we don't have this, the adequate amount of the lesion. For the bipolar, your lesion will be from here to here. Width-wise, it will be increasing. But beyond the tip, your needle will not be there. That means the same disadvantage that if you are putting the needle perpendicular to the nerve, then the chances of the failure will be very high. Is it clear?
Okay, sir.
Any other questions from anybody?
sir,
Hello,
how
sir.
long will the pain relief from pulse radiofrequency last?
As I mentioned there, that the pain relief duration is something between the 4 months to 24 months for the pulse.
Okay, sir. Okay, sir. Thank you.
So do we
Sir,
use,
I would like to ask.
Yes, tell.
I would like to ask. In your practice, which radio frequency you always provide for the patient, and how you decide which radio frequency is the best for the patient for the pain control?
I told you like that only, that I shown you the indications. Like you have to think. say for it, you have to just rationally think. And then you have to look for the guideline also. I told you I'll be sharing the guideline, what kind of radiofrequency should be done in which situation I'll be sharing it. But I already told you, I'm just again quickly recapitulating it. So suppose you are doing the radiofrequency for the the Gasserian ganglion. Will you use cool radiofrequency?
Conventional.
Will you use cool radiofrequency? So Donna, where is Donna? Will you
Yeah,
use cool,
here.
will you use cool radiofrequency for the Gasserian ganglion? Yes or no?
No.
Yes. No.
No.
Mm.
No.
No.
Why? Because cool radiofrequency is producing lesion, football size lesion. So all other important structures are there. Brainstem is very nearby. You should do a small size lesion because you need safety. So if you wish to do that in there, so you should not be thinking of doing a cool radiofrequency. You should be doing the conventional, because conventional radiofrequency causes a small size lesion. So now come to the sacroiliac joint. I'm giving you two extreme examples. There are other things as well. So sacroiliac joint, what are the innervation? Sacroiliac joint innervated by lots of nerves, starting from the dorsal rami of the L4, L5, S1, S2, S3, even S4. And also from the ventral rami, some nerves are coming. And there all the lateral branches goes, make a network of the nerve and then goes to the innervated. So now individually picking up of the nerve, possible, but still failure rate is very high because in a small branch might be escaped. But if you're having a very large size lesion, carpet burning, big bomb, so chances of escaping from the nerves is very less. So the cool radiofrequency is the choice for the sacroiliac, right? So you now rationally think the other areas. Facet joint. Earlier I used to think that the cervical facet, lumbar facet, we should not use it. But recent literature is telling, if you are precisely looking at the needle there, you can do there as well, cool radiofrequency. So conventional radiofrequency indication is mostly the Gasserian ganglion and some other, I already mentioned this, like lumbar sympathetic, like T2, T3 sympathetic. So, ganglion, impa. So the other areas like when you do where the small size lesion is enough. But where you need a large size lesion, like a genicular nerve, genicular nerve anatomical variation is very high. So if you're having a large size lesion, your the chances of success will be increasing. If you're doing it in the shoulder joint, so the capsular, the branches from the suprascapular nerves, very small nerves are going. If you're having a large size lesion, your chances of success will be increasing. So you just think rationally that whether you need a small size lesion or whether you need a large size lesion. If you need a small size lesion, go for the conventional. If you need a large size lesion, go for the cooled. And pulse radiofrequency, only one indication, as I told you, that is your dorsal root ganglion. Is it clear now?
Yeah, thank you. Yeah,
Okay.
clear. Okay, understood.
Excuse me, sir. What is the duration of pain relief in cooled radiofrequency in bipolar radiofrequency?
Cooled radiofrequency, bipolar radiofrequency, conventional radiofrequency, all are thermal radiofrequency. So here the tissue temperature goes up to 80 degrees. So the duration of pain relief is similar. It varies from 1.5 years to 3 years, sometimes up to 4 years.
4 years, up to 4 years. Okay.
Up to 4 years. But most commonly, it is something around 1.5 to 2 years. Okay?
And compared to pulse
Because all are doing
radiofrequency,
thermal radiofrequency. So cool, conventional, bipolar, multi-channel, all these are going to produce the duration of lesion is approximately 2 to 4 years.
2 to 4 years, whereas pulsed will have lesser duration of pain relief.
Yes, pulse will be up to 4 years, 4 months to 2 years for the pulsed.
4 months to
2 years,
2
24
years.
months.
Okay. Sir.
Yes.
Sir,
Yes.
can you treat the neuroma with the radiofrequency?
Neuroma treatment with the radiofrequency is possible, but not a choice. The cryo is a choice. I'm coming to the cryo. That time I'll be talking about the indications. Because why? I just told you, that if you're ablating a nerve, if you're ablating the neuroma, you're going to ablate the nerve, nearby nerve also. Only neuroma without touching the nerve is not possible. So what will happen? There, the deappearances and pain will be a possibility. So neuroma, like Morton's neuroma, one of the classical example, the best treated by the cryo.
All right, thank you, sir.
The cry I'll be talking right now. I hope
So
no
when
more
we-
questions.
When
Yes,
we
yes,
ablate
yes.
the- when we ablate the trigeminal ganglion, will there be loss of sensory supply of the face also?
Yes, gastric ganglion. Gastric ganglion class will be there the next week, next Tuesday. That time I'll be discussing it in detail. But remember that one of the very important side effect of the gastric ganglion radiofrequency ablation is your numbness. It's very common. Though complete numbness is not there, but patient might be telling that, okay, if I'm comparing this cheek and this cheek, it is 30%, 40% less. But normally this is not that, the hazardous, because the amount of the pain or the patient used to feel and little bit of numbness everybody is going to accept. But numbness is obvious. Without numbness, radiofrequency is impossible in the gastric ganglion.
So when maybe after 2 or 3 years when the effect goes, is there chance of differentiation pain in the trigeminal?
Yes, I told you, no, not 2 or 3 years. The differentiation pain is possible within a month.
Okay.
Yes, it's a possibility. And that is the reason why differentiation, okay, I forgot to mention this. How to prevent differentiation pain in radiofrequency. So whenever you are doing a lesion, you always inject a little bit of steroid there. So how steroid is going to help in preventing the differentiation pain? Steroid is having the membrane stabilizing effect. So what you have discussed there, that the mechanism of the differentiation pain is what? Crosstalk and ectopic signal. So that can be prevented by using the steroid. So that is the reason whenever you are doing a thermal ablation, always give small amount of the steroid before taking the needle out.
What is the volume? Dose steroid? Volume or dose of steroid? That is
Doses per lesion, we should inject around your 5 milligram of the depot steroids, and volume is half cc, 0.5 ml.
okay, sir.
Shall I go ahead with the cryoneurolysis now? Okay.
Yes, sir.
So,
Okay. So neurolysis, these are already I have discussed earlier. Advantage, disadvantage of this. So this I'll be going to this first. So already I have discussed it. That the first degree lesion, neuro. Yes. Tell me.
So one more doubt, sir. So
Yes,
if
tell.
using,
I am here to clear all your doubts.
so if we are using radiofrequency ablation not for any nerve lesions, like if it's being used to ablate some lesion in liver or something, this steroid injection will help in reducing the pain.
I didn't listen. Can you please recap again? Ask the question.
If we are using radiofrequency ablation to ablate some lesion in the liver or some organ, and if we inject steroid before ablating, that will reduce the pain caused by that radiofrequency ablation of that area.
You are talking about the tumor ablation.
Yeah, tumor ablation, sir.
Okay. So tumor ablation, nerve steroid injection is recommended for your nerve. For the tumor ablation, I am not a cancer specialist, so I have not done any tumor ablation with the radiofrequency.
We usually do not give any steroid in tumor ablation, and it doesn't help in any pain relief in tumor ablation, sir. And the radiofrequency probe and mission altogether, they are completely different from what we use in pain medicine.
Yeah, that is a completely a different machine. That is not the same as what we are discussing here.
Yeah.
Okay. Thank you.
Okay. Any other questions from anybody? No. So what I was discussing now is the different degrees of the nerve damage. So first degree is neuropraxia, and here the nerve recovers within the 30 minutes to 7 days. So there is no anatomical lesion, and there will be only the conduction nerve. Second degree, this is very important. Here the pain relief will be there between the up to 2 years. Here the other fibers recovers within 2 months. Other fiber is larger diameter fibers, and regeneration here will be perfect. There will be no sequelae here. The third, fourth, and fifth degree. So here only the no endoneurium, epineurium, perineum, nothing is damaged. So here third degree means endoneurium is damaged. Fourth degree means along with the endoneurium, perineurium is damaged, and fifth degree means epineurium is also damaged. So here third and fourth degree still recovery is possible, but the 5th degree recovery is not possible. But chances of the recovery after the 3rd degree is much more, and sequelae chance is less. 4th degree, chances of recovery is less, and sequelae of the damage is much more. And 5th degree, there will be sequelae, but there will be no nerve damage. There will be no regeneration possible. So now, in the radiofrequency, what kind of lesion is generated? It is the 3rd or 4th degree lesion is generated. But in the radiofrequency also, if we are trying to restrict our temperature within 80 degree temperature centigrade, then the lesion goes normally up to 3rd degree, not up to the 4th degree. Why we want 3rd degree? Because chances of the regeneration is more without sequelae. Sequelae means deafferences pain. Deafferences pain is much more with the 4th degree than with the 3rd degree. And it will be giving longer pain relief compared to that of the 2nd degree pain relief. 2nd degree lesion, the pain will be relieved by the coming back within the 2 years. Whereas 3rd degree, it can go up to 4 years. So now, radiofrequency causes your 3rd or 4th degree, whereas cryoneurolysis at a temperature of up to 100, minus 100 degree is going to create the 2nd degree. So the disadvantage of the cryo here is, here we are going to regenerate, the regeneration of the nerve will be perfect without any sequelae. So cryoneurolysis is not going to cause any deafferences and pain. This is the biggest advantage of the cryoneurolysis. So now the cryoneurolysis is the direct application of the cold and all those things. So this is a small history. So now this is the principle, how the cryo works. It's basically same principle as the refrigerator or the air conditions. So here gas is passed under pressure. Here is the constriction, and then pressure is suddenly released here. And then the wider board channel within the needle, the gas is coming back. So what will happen? Here the temperature will fall down, come down. And how long, how much temperature will be coming down? It depends on the freezing temperature. For the carbon dioxide gas, it will be coming up to minus 78 degrees centigrade, because minus 79 degrees is the freezing point for the carbon dioxide. So the gas used is your carbon dioxide. Here the temperature is possibly 1 degree less. That means it will be minus 78 degree. Here it will be minus 87 degree. So this is the temperature if you are using these two gases. So now, what what is our aim? Why we are concerned, or why we are people? The whole world is going towards the cryoneurolysis nowadays. Why? Because the sequelae of the lesion, nerve lesion, will not be there. There will be complete the regenerations and no sequelae. And second important thing is here, we are having the flexibility of having a very small size lesion up to the very large size lesion, depending on what kind of probe you are using. So if you are using a very small diameter probe, say for example 22 gauge probe, then you are having a very small lesion, like in the Morton's neuroma, like in the Baxter's neuropathy. You can ablate this very small amount of the small amount of the lesion, and you can precisely ablate the nerve. That is not going to create anything. But again, you can have a very large size lesion like the sacroiliac joint. You can even create up to 8 centimeter lesion. So we had the publications there, first publications for the cryoneurolysis in the sacroiliac joint. So there we have created the very large 8 centimeter size lesion with the cryoneurolysis. So these are the different probes cryoneurolysis. I told you this is the 22 gauge probe, very small size lesion. Here this is a little bit larger, still larger, and this is a special probe for the sacroiliac joint. So here it will be creating a lesion up to this length. So this is ice ball. See how is the size? It can be up to the, here this lesion is producing 10 centimeter length and around 10 millimeter length, and around white is around your 4 millimeter. But depends on what size of probe you are using. If you are using the small or large, there are different options here. There. This is your SI joint probe. You have seen almost 8 centimeter length. And what you can do is you can introduce this probe along the medial border of the sacroiliac joint, and all the the lateral branches can be ablated with this, and it's having a very good, very high success rate for this procedure. So this is the machine. I'll be showing you the machine also. These are the cryo probes. These are not the needles. You can't inject anything through it because gas will be coming back. But again, do we need to inject local anesthetic inside during the lesion? if we are doing the radiofrequency lesion, local anesthetic must be injected. It's very painful. Heat lesion, thermal lesion is painful. Whereas the cryo lesion is not painful. Cryo lesion causes immediate pain relief. Whereas radiofrequency, the procedure, it takes approximately 2 to 4 weeks time to have the optimum pain relief. Now, this is the mechanism. So what happens? The freezing of the blood vessel supplying the nerve, and that is going to cause the lesion. So now this slide is again very important. So how different degree of temperature is going to produce the different degrees of lesion. So if you wish to do a first degree neuropraxia, like your application of the code, how it is going to help? It is going to do the first degree lesion. And here the recovery, the temperature is +10 to -20. We are going to create a first degree lesion conduction block. Second degree, what is our choice? Is in between the -20 to -100. So this is for the second degree. If we are third and fourth degree lesion, more than -40 is going to produce the third or fourth degree. And with the cryo, the fifth degree lesion is not possible. With the radiofrequency, it is possible. And fifth degree lesion is obviously possible with surgical ablation. So there are certain advantages of that. What is that? Most important advantage is you can visualize this with the help of the with the help of the ultrasound. Put ultrasound probe, and the ice ball will be having hyperechoic shadows, and you can understand where is your nerve and where is your the lesion. So that gives the success. So cryoneurolysis have a very high success rate. Failure chance if you are doing under the ultrasound is very less. So no procedural pain, because immediately there will be pain relief. No need of any giving a local anesthetic at the site. Only thing is where you are injecting that area, you will be giving local anesthetic only. So you can even having the option to give the small size lesion to the large size lesion. And very important is the pain fibers normally regenerated something between the 6 months to 24 hours, but the motor fibers recovers very quickly, few weeks, so that the no permanent motor loss, even if you are inadvertently damaging it. No permanent your touch fiber loss, that also will be recovered like motor fiber very fast. So what will happen? In a mixed peripheral nerve, like say for example occipital or a intercostal nerve. So in all those areas, so your cryoneurolysis is the automatic choice. Somebody was asking neuroma, automatic choice is your cryo. So all these areas where the pulse radiofrequency was earlier done with the apprehension that you cannot damage the motor fibers, you cannot damage the sensory touch fibers. So all these areas, the cryoneurolysis is the choice. So Amit Barnwal has raised the hand. Okay, Amit, tell me what is the question?
Good evening, sir.
Yes, yes.
Sir, in the last slide, you just showed that for third degree nerve block, -140 degrees centigrade is required. But with the two gases which we are using, the first one we are achieving -79, with another we are achieving -80. So how can we expect a third degree nerve injury on third degree?
Third degree, you have to use the different gas. Means with the same gas, you cannot change the temperature. So when you are using carbon dioxide, you'll be able to achieve the temperature of around -70 to -78. So if you wish to have the temperature closer to this -40, so you have to use a different gas whose freezing point will be close to that. That means how minimum temperature, and the machine setup will be different. That is not commercially, the available machines. But theoretically, you have to understand that what kind of temperature you wish to achieve with the cryo, it depends on the hot gas you are using there. So for the cryoneurolysis, when you're talking about the pain management, our aim is to create the second degree lesion. So here your option is two. One is your nitric oxide, another is your carbon dioxide. So machines like what is available in the market, these are having the options. You can put a button, what gas you want to put. If you wish to put the carbon dioxide, then you select the carbon dioxide button, and then you start the machine, or vice versa. So if you are using carbon dioxide, your temperature will be fixed. If you are using nitric oxide, your temperature is fixed. So you cannot, like radiofrequency, what has happened? Same machine, you can go at any temperature. You can set temperature 60, you can test temperature 70, 80, 85. So here it is, that flexibility is not there. Here you have to change the gas to change your the temperatures.
Required temperature. Yes.
Understood?
Yes, sir. Thank you, sir.
Okay. So these are all the different advantages. Most important advantage is that there is no differences in pain. Second important advantage is that you can directly visualize the lesion under the ultrasound. Third important advantage is that it is going to create a different size of the lesion from very small to very large size lesion. Another important advantage is that the procedure is pain-free when you are doing the procedure. It is not going to, you need not give any local anesthetic injection. On the table, the patient will be getting the pain relief. So there is a certain disadvantage, advantage. But disadvantage are what? Disadvantage is slightly lesser duration of pain relief compared to the RF. RF you can get up to the 4 years pain relief. Here you can not going to get that much of duration of pain relief. So that is one of the important disadvantage of the cryoneurolysis. Otherwise, cryo is going to, replace the scenario in the, if you are going to the, that current trend is the cryoneurolysis. Earlier, cryoneurolysis was not that popular because the different size of the lesion was not possible earlier. Now we are having the, another important thing is, if you wish to change the size of the lesion, you have to change the probe. With the same probe, you cannot different size of the lesion. Okay, so these are the contraindications, these are the side effects, and this is the, so here we are doing the genitofemoral. So this was the femoral artery dipping here, and your needle is very close to the nerve. This was the nerve, and this is the lesion. So the lesion, the ice ball, and that will be casting the acoustic shadow there, and you can see where is your needle and where is your nerve. So this is another the genitofemoral nerve. This is the same one. This one after the lesion, the ice ball is produced. So this is one scar neuralgia. Scar neuralgia is another where we can keep the radiofrequency probe just below the scar, and because it is going to create a large size lesion, it will be ablating the finer nerves coming from the scar tissues, and it will be having fantastic, excellent results. So these are the different uses, as I told you, that you can use it in different conditions, how the radiofrequencies are used, and particularly the pulse radiofrequencies, and why you need to have a large size lesion. So these are all different kind of the indications. So thank you very much. And if you have any question, you can ask me, and I'll be just quickly demonstrating the radiofrequency machine, and I'll be showing you one lesion over the egg yolk, and then I'll be showing you the cryo machine also. Any questions regarding cryo?
Good evening, sir.
Yes, tell.
Sir, what is the approximate cost of this cryo machine?
Cryo machine cost is approximately 25 lakhs. But more important is the cost of the probe. So you need to have a different varieties of the probe, and each probe costs something around your 1.5 to 3 lakhs. And probes cannot be used more than 25 to 50 times. So after certain times, the probe can be harmful. It can cause accident because it has to withstand a very high pressure of the gas, and it is a very fine one. So that's why company itself has the, you have to, how many times you are using, machine will be registering it. So once your 25 times is over, then you cannot use the same probe again. So that altogether it comes a little bit costlier than the conventional radiofrequency. But if you are comparing with the cool radiofrequency probes are also costly. So if you are comparing with the cool radiofrequency versus the cryo, it is almost similar at par.
Thank you, sir.
In your practice, which is the major indication you have used cryoneurolysis?
Cryoneurolysis is very popular in the class. Cryoneurolysis is the most important indication in the peripheral mixed. As I told you, peripheral mixed. Say for example, one of the very common indications.
Audio is not clear, sir.
Yeah. Is it clear now? Am I clear now?
Somebody's mic is on.
Okay, I made then mute. So am I audible now?
Little better, sir, but not
Not
as
as
clear.
clear. Yeah.
Not as clear as before.
I have not done anything. I'm the same person sitting in front of the computer.
You have adjusted your mic, I think.
Okay. So I hope it is you can understand my voice, isn't it?
Sir, can you please raise your voice?
Raise your voice, okay? I'm raising my voice. Is it clear now? What you asked me? I forgot the question. What was the question?
What is the most common now?
Okay, why we are using it? So I was talking about the intercostal nerve. So intercostal nerve, it has the sensory supply. It has the the skin supply, cutaneous supply. Remember, cutaneous supply is the most notorious to develop the DFT. It is supplying the it has the branches, anterocutaneous now, lateral. So all the reasons are there. And most important part is it is having the important the motor fibers. I can remember one thing. I'm telling the story. I did a blunder in one case. So I am talking about the long back. That time I didn't have the diabetic. The Radiofrequency machine was there. So you can remember the further intercostal levels here. What is the treatment option? It is the pulse radiofrequency. So I got a patient who was having the anterior pain, and my diagnosis was exactly, I don't remember, probably thoracic 9 or 10. What was my diagnosis? What I already did is any other. Initially, patient was investigated a lot for all the abdominal pathologies. Everything came negative. And then the patient came to me, and my diagnosis was intercostal neuralgia. And what I did was the diagnostic block in the intercostal nerve, and patient was having fantastic pain. After so many years, patient was so happy after the diagnostic block. But diagnostic block is not enough. So what I did the pulse, but it didn't work. So again, patient came back. So what I did was I did a thermal lesion with a lower temperature. If you're doing the lower temperature, then the degree of the lesion is less. So I did the lower temperature. Patient was coming to very long distance, So it worked. Patient was very happy, going back. But again, because the temperature was less, the patient's pain relief was lasting only for around 3 months.
Sir, your audio is not that clear.
It's echoing. It's echoing.
Echoing. I have not changed anything. How it is possible? Okay, I'm changing the microphone.
Yeah, it's better now.
Now
Good.
it's better.
No, sir. Not audible. Without mic itself, it was audible. Sir, it's not audible.
Hello.
Yeah, sir. Now it's audible. Clear.
Now it's clear.
Yeah.
Okay. So what I was telling that situation. So first I did the pulse RF, it didn't work. Then I did the thermal ablation with the 60-degree temperature, 60-65 degree. It worked, but only for a few months. And then the patient came back again for long distance and saying, okay, only pain relief was only for a few months. So again I did it, but this time I did it at 70 or 75-degree temperature. And you know what happened? There was a hernia. Why? Because that is causing the lesion of the motor fibers also. So lower motor neuron lesion. So flaccid paralysis. So there was hernia. So after that, I never did any thermal lesion of the thermal lesion is basically not needed. One should not do it. But because pulse was not working, so these are frustrating areas. How to do in these situations? Local anesthetic steroid is giving only very short pain relief. Pulse RF is not going to give it. So intercostal neuralgia is one of the common indications for me in my practice. where I do the cryo, which is not going to do any motor or sensory lesions. Second is your occipital neuralgia. Literature wise also it is telling. Gastrin ganglion, when it is the first division is involved, because we don't need any first division. What is the problem with these things, with the radiofrequency? That there might be corneal anesthesia that is supplied with the ophthalmic division. So you can't do that. So that is one of the areas where you can do the cryo. Then is your the peripheral nerve, like as I shown you, the genitofemoral neuralgia, the meralgia paresthetica, the ilioinguinal iliohypogastric nerves. So all these are the areas where I do. These are the peripheral nerves is the most important areas. But I have also done the sacroiliac joint. As I told you, sacroiliac joint cryoneurolysis was our first publication in the whole world, where we have done the cryoneurolysis of the lateral branches of the sacroiliac joint. And also in the genicular nerve, also there also you can do the cryoneurolysis. So I have done in all those situations. If you're telling the most common areas is your intercostal nerve. Okay.
How good is your counseling, sir? Like, do you take consents for all the side effects? I mean, do you explain all the?
Yes, obviously, you have to explain the other side effects. You have to. Whenever you are doing the procedures, you have to tell what are the advantage, disadvantage, and you have to prove that your advantage is more than the complications in the side effects. So that is the way I told you. Radiofrequency, the numbness is always a possibility. You have to explain the patient that the numbness is a possibility. So if the patient don't accept it, so you can't go ahead. But most of the times, what happens, so these side effects are not that very serious, and the intractable pain patient is ready for anything.
Good evening, Dr. Gautam. For a question.
Yes.
In cases of severe knee osteoarthritis, when we do RFAs for the genicular nerves, how do you counsel your patients, and what are the complications you've seen? And also, do you inject steroids after you've done the RFA?
Yes. So counseling is same. Mostly you remember the genicular nerve ablation should be reserved only for those patients where it is a very advanced osteoarthritis and where the TKR is not is an option. If you are asking me, shall I offer this genicular nerve ablation in a patient where the very bad osteoarthritis, range of movement is grossly deformed, or the range of movement is restricted, am I going to do it? Answer is no. So if it is grossly, if you can tell the different, the grades of the radiological grading, up to grade 3, I do normally regeneration therapy, PRP and VSCO. In grade 4, I always ask the patient to go to my orthopedic surgeon friends to go for the total knee replacement. But suppose in any situations, patient cannot do, maybe sometimes because of the economic conditions, sometimes because of the other comorbid conditions, bad cardiac or other complications. So those are the situations I go for the genicular nerve. Genicular nerve I do not offer routinely. Another situations I go for the genicular nerve where the TKR is a better option, but the patient is very young, maybe around 45 years of age. So that is not the right age for the TKR. So there also I try to defer the TKR. I tell the patients clearly that TKR is the option, but I am trying to defer your TKR. Maybe 1 or 2 times I'll be doing the TKR so that I'm buying another 10 years time so that after that you will be going for the TKR. So, so it is not an alternative, but still I do the genicular nerve ablations in these patients, and there the best way to do it under the ultrasound guidance, you identify the genicular nerves. But apart from the genicular nerves, there are other options. Normally, I discuss these options in the because the knee innervation is a big chapter itself. There are lots of nerves, not just genicular nerves, which are innervating the nerve. So only genicular nerve ablation is not going to give a very good results. So you have to target the many other nerves together. And complications with the radiofrequency is not that very serious. I have never came across with any single complication of the radiofrequency. But in the book, it is written that you might be puncturing the artery, genicular artery, which is accompanying the nerve, and there might be aneurysm. This is one of the complications which has been written, documented in the book, but I never came across such. What I came across is a failure, like I have done, and there is no results. So this kind of things are there, and the reason is the knee is innervated by at least seven nerves, and unless we are addressing all those nerves, the failure rate is very high. So that is the only one which is not a complication, but it is a treatment failure. And if you are searching the literature, you'll see that the radiofrequency ablation of the knee is having a success rate of something around 49% to 70% on. And I am doing PhD, at this age, I'm doing PhD. And my PhD thesis is on this genicular nerve ablation versus cryoneurolysis. And I'm comparing these two. So the genicular nerve radiofrequency ablation nowadays is becoming less and less popular. You know why? Because so many nerves, it is not very patient friendly and chances of failure is very high. So nowadays in the advanced osteoarthritis, if up to 3, I always prefer for the regeneration therapy. It is having a better success rate. And if not, if at all you need to go for the radiofrequency or nerve ablation, you have to pick up all those different nerves as well. Then only you'll be getting bigger. Okay.
Thank you.
Sir, after cryoneurolysis, can we visualize with ultrasound how it will be?
Cryoneurolysis lesion will be visible under the ultrasound. When you're holding the ultrasound probe, you'll be able to see the ice ball there. So, and you can see the nerve or vessel, and you're close to the nerve. I'll be showing you, posting you some video. I always tell that, okay, please go to the Daradia's YouTube channel. Lots of cryoneurolysis videos are there. So you just see those videos, how we are doing it, how the lesions are created. You can see that gradually ice ball is formed. The other structures, acoustic shadows are there, and then again the lesion is. So please search the cryoneurolysis in our YouTube channel. You'll be getting lots of videos.
Okay.
Shall I start demonstration?
Yes, sir.
Okay. Just give me 2-3 minutes time. Let me do the setup. Let's go. Okay, Shruti, are you there? Shruti?
Yes, sir, I'm there, sir. Can I start
Okay.
now, sir?
Yes, you start. Meanwhile, let me prepare the setup. By any means, the camera is not working nicely. So
Okay,
that,
sir.
is it coming?
Um,
Okay, just a minute. It is
Okay.
there. Just
okay,
a
sir.
minute. Okay, now we can see the things, no?
Yes, sir.
Hello? Can you see me? Can you see the machine?
Yes, sir.
Yes. Yes, sir.
Okay, okay. So this is the radio frequency machine. So this is the screen. And here, first part is your, this is the touch screen part. And here the first part, this part is your electrode selection. So electrode selection means
Can you
what?
turn the screen, sir? Can you turn it to this side? Little onto the, right, sir. Right, sir. Yes.
Okay. So this part is your electrode selection. Then this part is your stimulation. So you are going to, you can, if you are stimulating it, I was telling you, this is your motor stimulation, 2 Hz. You can do the sensory stimulation in the 50 Hz. So then is your, this is your thermal lesion. So here we have selected the bipolar lesion, and that is the reason why one is showing 42, room temperature is 24 degrees centigrade. So it is showing 24 degrees centigrade in both the tip. And this is for your pulse rate frequency. Pulse rate frequency again, that is a different windows. So first what we are doing it here, we are doing the 2 electrode bipolar I am selecting. So there are 2 electrodes there. And then what you need to do after pressing the needle, then you should be stimulating it, any sensory stimulations and the motor stimulation. And after that, you should be going for the lesion. So this is for the lesion. And now what I am doing it, I'll do catching. So we are going to create a bipolar lesion. So can you see the needle tip there over the egg? And now I'm starting it. And you see the tip temperature is rising. As I was telling you, normally when you're doing the bipolar lesion, one tip temperature, one tip becomes the active one, another is the passive one. The active tip temperature goes up. Here I have set temperature is 80 degrees. This is going to rise very quickly. The other one is rising a little bit slower. So you see here, it is going 80 degree, 81, again coming back. Sometimes it might be coming 79. So in that it's 79. So what is important here? You look at the wattage here. This wattage is you see it is getting fluctuated. So when it is going high, you just look at this here and here. When it is going low, then it is going higher. And when it is going higher, it is coming lower. So but that means by controlling the wattage, the tip temperature is controlled because you are doing it as a conventional, the radio frequency. And you can see here, the lesion is produced there. I'm stopping it here. And it just, so you see the lesion is produced in both us. Here the small lesion was there in this, and it actually.
We can't see the egg clearly, sir.
Clearly? Can you see now?
Light is reflecting, sir, basically.
Reflecting. Is it okay now?
Better, sir.
Okay. So basically there is some, the small area where the temperature is produced, and because we use bipolar, so the 2 lesions are produced simultaneously. One was active, another. If you was doing the multi-channel lesion in the same way, then what you need to do was you have to activate the ground pad as well, and then that will be completing the circuit with both the electrodes together. So here the other options, as I was telling you, other very important areas is the sensory stimulation, motor stimulation, and this is the pulse rate. But again, remember the basic, this machine and the other machine, the basic features of the machines are similar, and these are the basic buttons what are there in every radio frequency machine. Now I will be showing you the cryo machine. Cryo machine's demonstration is not possible there. Yes, if you have any questions regarding the radiofrequency machine, you can ask me.
Yes, sir. You told for a sensory stimulation as 50 hertz, whereas motor it's 2 hertz. Why there is a vast difference in that current?
It is the body. This is the physics. So this is, if you're asking why, I cannot say. So I told you at the beginning, the motor fibers are stimulated at a lesser range of current. Between 1 to 10 hertz, the motor fibers will be stimulated, not the other fibers. Then if you're increasing the current frequency further, so 20 to 40 hertz, your A beta fibers, touch fibers will be stimulated. Then if you're increasing the frequency further, 50 hertz to 100 hertz, your small diameter A delta and C fibers will be stimulated.
Okay, sir. Okay.
So now if you're asking why this is going
okay,
to
sir. Okay, sir.
fibers, that question I don't have. I don't know anybody have or not.
Okay, because it's a vast difference, so I asked. Okay, sir.
So I'll be bringing the cryo machine. So this is a cryo machine. So here again, there is some panels are there. So different buttons are there. So what is important here? There is a carbon dioxide cylinder here. And that carbon dioxide cylinder is attached at the back of this machine. And here, like here, you can see the button, the carbon dioxide, or if you are putting that button, there will be another option, will be a nitric oxide. So you can nitrous oxide, sorry, and that you can change it, and it is almost similar because the freezing point is similar. And the gas will be coming here, and you can see this is the probe. So this probe, can you see the probe? So this probe is a blind tip. So the tip, you cannot inject anything. So you cannot inject local anesthetic, and it is not needed also. So gas inside will be coming and going back in the inner channel, and that will be creating the lesion. And the different size of the probe are there. And here also, before doing the lesion, we are having the stimulation also. So neuro stimulation option is there. We are pressing there. So sensory stimulation, the motor stimulation, we can stimulation selected. So motor stimulation. So all these stimulation, the motor stimulation is again for the 2 hertz. And sensory stimulation selected. And sensory stimulation is 50 hertz. So this is how, this is the standard as I was telling you. So before doing the lesion like your radiofrequency, the same way, here also, you stimulate it and then only you go for the lesion. You must be sure that you are basically doubly sure. One is you can stimulate the nerve and you can sure that you are close to your target nerve away from your other nerves. And at the same way, you can visualize it with your ultrasound probe. So these are different, this is one, very small lesion, 22 gauge to 22 gauge, the lesion size. White twice. This is little larger. This is your the 18 gauge problem, and this is your 16 gauge. So this is the 18 gauge, and this is going to create the very large size lesion for the sacroiliac joint of around 8 centimeter length. So this is another. This is your 20 gauge. So all the different kinds of probes are available. This is a very small one, and of the 22 gauge needle. So this is normally used for the motors, neuro, or vectors. So as I was telling you, with the cryo advantages, you having the option of having a very small size lesion to very large size lesion. Okay. Any questions regarding the radiofrequency and cryo?
Sir, cryophobes, can we introduce? Is it like a needle? It's looking like some silicone material. How
It
can
is
we
like
introduce it?
it is needle only. I'm showing you again. Hey, একটা needle এতে তো।
Needle only. Okay, you can
It
pierce
is
through
only
the
needle.
skin.
It is like needle. Can you see it?
Okay,
Can
sir.
you see it? It is needle only. So part is insulated because you need to have the stimulation, and the tip is not. But that is not an electrode only when you are stimulating it. In other type,
Okay, so we have to extend the incision.
no. Why incision? Because needle is sharp, tip is sharp. Why you need needle incision? Tip is sharp. You see? Can I appreciate that? Tip is
Yeah.
blunt. Tip is not open, but it is not means it is sharp. Don't need an incision. You can prick it. But sometimes for larger gauge needle, if you are giving a small nick with a other large gauge needle, what I do when I take the larger gauge needle, I do a small nick with a 16 gauge or 14 gauge needle, and then I put the needle. Then that will be easier for introduce the cryophobia.
Tip length is same for all the cryophobes, sir?
No, I told you, I have shown you the length is different. So some are very, very big, some are very small.
So depending on the places we are
It is
introducing.
your choice what kind of things you wish. Suppose if you wish to the very superficial, like I told you, the Morton's neuroma. So it is superficial. You need only approximately 2.53 inches enough. But if you wish to do the facet joint, you have to have a larger size, 10 centimeter or more than size. Okay. So depending on where you are doing the lesion, you should be having the all different choices of the cryophobia.
Okay, sir. Thank you, sir.
Sir, what is the basic difference between the pulsed RFA and conventional RFA?
You tell, I already explained it. So basic difference is pulsed RF is not a thermal lesion. It is an electromagnetic field effect. There is no ablation of any tissues. It is not a thermal radiofrequency. Whereas conventional RF, cooled RF, bipolar RF, all these are thermal lesion. It is going to create the heat and it is going to ablate the nerve with a heat lesion, thermal lesion. So this is the basic difference. Okay.
And how does it helps in decreasing the sensation of now?
Huh? I mentioned this. You was not there during that time when I was explaining. Have you joined late? Probably you have not listened that time when I explained this. So pulse radiofrequency is going to help. How it is going to help, how it is going to decrease the pain sensation, still not known. So one of the hypotheses is interleukin level of the analgesic effect, who is having the analgesic effect, that kind of interleukins levels might be going higher. That is one of the hypotheses. But still it is not knowing, but pulse radiofrequency have a very high failure rate. The only indication where it works is your cervical dorsal root ganglion. Okay, you just listen, the recordings will be given to you. You just, all this has been discussed in every detail. So you just go to the recording and listen these areas, what I have told.
Sir,
According to you,
one thing, sir, recorded videos we are not able to open. Some are written as a private videos.
No. The recorded videos all are opening. I have tested it.
You have tested, sir, because last time also somebody told.
No. There is no record. All the recorded videos are available. Only thing is that only those earlier videos. Normally, we told that it will be available for 1 month, but because many are requested, I have kept it for the full entire month. And only those videos which was there in the earlier. So some of the videos might not be there, but all other videos are there. And apart from that, the earlier classes recordings are also there. There are basically, to get these videos, there are 3 areas are there. One is your YouTube links, one is your uploaded videos, another is your recorded videos. Basically, all are same, different lectures. Like I am giving this lecture at least 25 times. So all those earlier videos, lectures are there, same recording. So some are there in the uploaded in the YouTube channel, which links are given. Some are there in the uploaded videos you have seen. So you just go through that uploaded videos. You'll be getting everything is there in your website is there.
Sir, in these recorded videos, no, in this session of your recorded videos, the first 1 to 2 module is not coming.
Not coming because I told you initially in the course, it was told that only it will be available for the 1 month. But what I'll be doing, I'll be make them available because we are going to go for the exam. So I'll be making it sure that all the recorded videos, even the first 2 videos or 3 videos also will be available for you.
Okay. And in
The
between, sir,
module 9 is also not available, sir. Module 9.
Recorded videos after
Yes,
second
sir.
and third, all are available. So how it is possible that
Third
nine
and
is not available?
sir, third and fourth is also not there because that time class wasn't taken. And the 9th one is also missing.
Sir, can you please recheck it because we
Okay,
don't
what
have.
I am telling you, you just listen it carefully. That the recorded videos, YouTube videos, and the uploaded videos all are same. If you are not getting it, suppose you are not getting the module 3 in the recorded videos, you open it to the uploaded videos. If you are not getting in the uploaded videos, you go to the YouTube channel. So all the videos multiple times in 3 areas so that you are not missing any of the videos. It is uploaded in all 3 different areas. Understood? These are the same videos. Okay. I'm sure that you are not reading all the videos, otherwise these complaints would not come because it is all the same videos.
So the third and fourth class was not taken because of some
technical issue. It is there. You just read the uploaded videos. It is the same. I made sure I personally checked it. There is no single lesson, single lectures are missing.
Okay, sir. Yes. Thank you, sir.
You just check it to the other areas. One is recorded. I am telling you again. There are different buttons are there in the website. One is there recorded video. One is there the uploaded videos. Another is there in the YouTube videos. All videos are same. Only different classes.
Okay, sir. Yeah. Thank you, sir.
Sorry, sir. I got one question.
Yes.
Sir, what is your opinion about cryoneurolysis of infrapatellar branch of saphenous nerve in chronic knee OA, sir?
Yes, you can do that. That is one of the very important option. But unfortunate part is interpatellar branch of the saphenous nerve is not seen in the at least 50% situation. So there is a better option. What is a better option? You can go a little bit higher and you can in the adductor canal, subsartorial plexus block, you can put the cryo probe there and you can ablate the adductor canal with the cryo. What is the advantage? Because there is another important nerve is there, which is your nerve to vastus medialis. So nerve to vastus medialis also have very important supply to the knee joint capsule. So instead of targeting the interpatellar branch, which is many times it is difficult to see, you can go little above and do the subsartorial plexus block. In fact, subsartorial areas, the nerve block in the subsartorial areas without targeting any individual nerve. That is one of the very recent upcoming areas where the people are doing it. And sometimes they are giving in the 5% dextrose also in the subsartorial areas, which is giving good result. But what you told it is definitely is a good option. How you can target the interpatellar branch of the saphenous nerve. But as I told you, it is very tiny branch and many times it is very difficult to identify.
Thank you, sir.
According to you, cryo is the future. Is there anything where you
Future
have?
Will be coming. I cannot say that I am not the, but I feel the cryo is coming in a bigger way. Yes, tell me.
Yeah, where is it you have switched? I mean, which area, which nerve block or radio frequency ablation you have switched over to cryo? Which area of it?
Like in the knee. The knee is still now evidence is there for the radio frequency. But I am seeing the cryo is fascinating. I told you, my PhD paper is radio frequency versus cryo. Then another important area is the sacroiliac joint, where the best evidence is a cool radio frequency, but our paper is telling that the cryo is a very good option. You can create a very large size lesion without any damage to any other structures, give very good results. I have done it in the facet joint. I have done it in the gastrin ganglion. I have done it in the other indications where the radio frequency was done. And cryo can be done in all other situations. Only disadvantage of the cryo is all other advantage. Only 2-3 disadvantages are there. I should not be telling you. I must be honest. I should not be talking only in favor of cryo. One of the disadvantages is that when you're putting the cryo probe, the problem is that if we wish to go for you have seen the cryo, you have to attach with the machine which is coming the carbon dioxide. So that pipe. So when you're doing under the ultrasound or under the serum, so the perfect tunnel vision is difficult to see because cryo base is very big. So that will be obstructing your needle tip. So that creates some practical disadvantage of putting the needle in the tunnel vision. This is one disadvantage. Second disadvantage is that your target structure is little deeper, and if you wish to traverse a large path with a cryoprobe, so it might be a little bit painful because you are injecting the local anesthetic steroid. It might not be painful when you're doing the cryo, but putting this in the track, it might be a little painful. Then another disadvantage is the duration of pain relief is little shorter than the radiofrequency. These are the few disadvantages. But cryo can be done in all other indications how the radiofrequency are done. But the advantage, disadvantage, you have to think. The natural options for the cryo is your peripheral nerves, peripheral nerves, like your intercostal nerve, like your occipital nerve, like the ilioinguinal genitourinary nerve, your meralgia, the lateral cutaneous nerve. So these all are the options for the cryo. But you can do it in the other situations as well. But your future will be telling, because ultimately it is the era of evidence-based medicines. So unless the evidences are there, so you cannot tell that this is, you have to either create evidence or you have to follow others' evidence. Okay, so it's almost 8. So let Shruti start. They are waiting for a long time. So fibromyalgia and the myofascial pain, two other options, two other very important, the very common, basically okay, Shruti, I have not made you, the.
Yes, sir.
co-host.
Please make me co-host, sir.
Yes, I'm making a co-host. Sorry, I forgot. And where is Sneha? Okay, Shruti, you can select,
Okay, sir.
you can share your slides.
Yes, sir.